In the next few classes, we will introduce several hereditary hemolytic disease. Hereditary spherocytosis is a disease of membrane cytoskeletal defects. Is the focus of this lesson. Glucose 6-phosphate dehydrogenase deficiency is the most common type of enzymopathies. Thalassemia and sickle cell syndrome are the representatives of hemoglobinopathies. They will be introduced later. First, we will introduce hereditary spherocytosis. This is a picture of the membrane of red blood cell. You can see that within the lipid bilayer, several membrane proteins, of which band 3, it is also called anion exchanger 1, is the most abundant. The alpha-beta spike chain dimers that associate to form most of the cytoskeleton, and several proteins such as ankyrin connect the membrane to the cytoskeleton. Mutation of membrane protein, usually ankyrin, occasionally spike chain, band 3, band 4.2, leads the membrane protein defects. That is called hereditary spherocytosis. Mutation of these proteins results in reduced vertical association between the cytoskeleton and membrane, which in turn leads to microvasculation and progressive membrane loss that reduce the ratio of red blood cell surface area to volume, creating spherical cells. Once red blood cells become spherocytic, successive phagocytosis during repeated passes through the splenic course promotes further membrane loss and progressive, more spherical shaped cells. It is hereditary disease, often autosomal dominant. In this picture, you can see the small spherocytes as arrow indicated. Clinical features are variable. It can present at any age and with any severity. The majority of affected individuals have mild or moderate hemolytic anemia. Neonates with hereditary spherocytosis often present with jaundice and hyperbilirubinemia. The serum bilirubin levels may not peak until several days after birth. In older children and adults, the presentation may be that of an accidental finding of hemolytic anemia or spherocytes on the blood smear, or the individual may be symptomatic from anemia, splenomegaly, or pigment gallstones. Acute exacerbation of anemia may occur in certain settings, which is also called aplastic crisis, such as parvovirus infection will impair red blood cell production in the bone marrow and thus diminish the capacity to compensate for chronic hemolysis. Conditions that increase the size of the spleen, such as infectious mononucleosis, may cause increased splenic pooling of red blood cells and increased hemolysis. Individuals who develop folate, vitamin B12, or iron deficiency may be unable to produce sufficient red blood cells to compensate for those lost by hemolysis, thus develop acute exacerbations. Pregnancy has increased demands for nutrients, which can also lead to aplastic crisis. So, supplement with sufficient hematopoietic raw material is important for prevention of aplastic crisis, especially during pregnancy. Laboratory features are as follows. Spherocytosis is greatly increased, usually more than 10%. In neonates or infants, significantly increased mean corpuscular hemoglobin concentration is highly suggestive of hereditary spherocytosis. Osmotic fragility test is increased. In this test, red blood cells are incubated in hypotonic buffered salt solutions of various osmolarities, and the fraction of hemoglobin released due to hemolysis is measured. The test takes advantage of the increased sensitivity of spherocytes to hemolysis, which is due to their reduced surface area to volume ratio. Others about hemolytic anemia is positive, such as increased indirect bilirubin, reticulocytes, and so on. Paravirus B19, herpes simplex virus, and EB virus should be detected when aplastic crisis occurs. Treatment of hereditary spherocytosis is directed at minimizing complications of chronic hemolysis and anemia. For those with moderate to severe hemolysis, folic acid supplementation is suggested, which can help prevent aplastic crisis. Blood transfusion is often required in severely affected infants and may be needed during certain times in other settings, such as aplastic crisis or pregnancy. However, long-term transfusions may cause iron overload and should be avoided. Erythropoietin may be helpful in reducing the need for transfusion in some infants. Typically, this can be discontinued around the age of 9 months when the children can produce enough erythropoietin. Splenectomy is effective because spleen is the main site of red blood cell destruction. However, operation should be performed in patients over 6 years old, and vaccine for pneumococcus, Haemophilus influenza, and meningococcus should be given before surgery to prevent infection. Okay, that's all. Thank you. Next, we will talk about erythrocyte glucose 6-phosphate dehydrogenase deficiency.